Okay, great. Hi, everybody. It's Maura here, and I want to thank you for joining us for this really important conversation. It's a conversation about racial equity, and specifically how we can collectively promote racial equity in opiate use disorder treatment and recovery services. Now, I'm really thrilled this morning to be able to welcome our distinguished panel of healthcare providers and leaders. They're going to share with you the ways that their organizations are providing accessible and equitable services to diverse communities all across our state. So joining us today, Dr. Kiami Mahania, who is the Chief Executive Officer at the Lynn Community Health Center, doing great work. Dr. Louis Chow, the Senior Director for Training and Network Development at the Home Base Program. Dr. Madeline Alvarez Hernandez, who's the VP of Behavioral Health and Recovery Services at the Gandara Center. Dr. Abigail Judge, founder of MGH Connect and psychologist at the MGH Bridge Clinic. Dr. Jesse Gaeta, Chief Medical Officer at Boston Healthcare for the Homeless Program. Dr. Kelly Saiha, who is the Director of Project Respect, the Substance Use Disorder and Pregnancy Treatment Clinic at Boston Medical Center. Now, together, these individuals belong to organizations that my office recently awarded grants. We were able to provide about $1.5 million to 16 organizations around the state to support and expand their work to provide recovery programs and behavioral health services to Black, Indigenous, and people of color. Now, I know that we have other grant recipients listening in on this conversation today. I just want to thank you all for sharing this commitment to providing innovative solutions to make opioid treatment and recovery services more accessible and equitable for communities of color. So we decided to create this program because it's so overdue. I think we saw through the COVID pandemic the exposure, the exacerbation of so many of the disparities that exist in our system that have been created and persisted through centuries, really. Certainly in COVID, we saw the exacerbation of inequities and barriers to healthcare that have disproportionately harmed Black and Brown communities for far too long. We're seeing some more of that play out right now when it comes to who's getting vaccines and who's not getting vaccines. And these disparities are heartbreaking. They're also unacceptable. And, I believe that we need to be very intentional about our engagement on issues of racial disparity and inequity if we're going to truly address those issues. Now, at the same time we have COVID raging, we also have the existing opioid epidemic. That hasn't gone away. It's still ravaging lives around our state, individuals, families, communities. We lose over 2,000 people a year, and the numbers are in fact climbing in this time. We know as well that, the opioid crisis is seen by many as a crisis mainly impacting white, suburban, and rural communities, but that's just not true. People of color are increasingly affected by opioid use disorder nationally. From 2015 to 2017, opioid-related overdose deaths increased for people of color, including 100% increase for Black populations. We know that people of color have also faced higher rates of incarceration for nonviolent drug offenses. And Black and Brown people have substantially lower access to recovery and treatment services, and too often experience less culturally responsive care. So we have to take action now to address these inequities, which is why we developed this grant program. The grant funds will go towards recovery and treatment options that are accessible and that are targeted. Programs that are intended to meet people where they are in the communities they live in and using culturally and linguistically appropriate care. The funds will go towards innovative solutions. We want to encourage providers to invest in a range of treatment practices that center diverse patient needs. And this grant is going to help remove traditional barriers to treatment that disproportionately harm communities of color. We must ensure these populations have access to the support they need to overcome substance use disorder. And through this program, I believe we can improve the health of Massachusetts communities of color and build towards equity in treatment and recovery. I think the disparate impact of COVID-19 provides a really somber reminder of the healthcare system's fragilities and the failures to equitably serve our most vulnerable residents. And so there is an urgency and there is an opportunity as we build forward in this moment, this national movement for racial justice. And that certainly has to start right here in our neighborhoods, in our cities, in our Commonwealth. And the good news is, with organizations like the ones here today, doing all that they're doing, we can make a difference. So I just want to thank you for being here. And now let's get to the heart of this where we can learn more. I'm going to turn it over to our speakers for their on-the-ground insight into this problem and innovative ways on how we can solve it. So with that, I think I'd like to talk to Dr. Chow. Again, Dr. Chow is from the Home Base program. And I'm wondering, Dr. Chow, if you could speak to some of the unique barriers that veterans, service members of color face in recovery, and how these grant funds help your program.
Thank you, A.J. Healy. An important part of Home Base from when we started 11 years ago was realizing that we couldn't follow a model of if you build it, they will come. There's this understanding that no matter how state-of-the-art the services are, how robust the treatments are, we have to be able to constantly engage in our communities and break down barriers to care. And what we knew from the get-go was that for those who have served in the military, there are a lot of reasons to not reach out. And as we've been thoughtful in breaking down those barriers, it's also been highlighted, as you mentioned in 2020, that there are so many disparities that continue to exist when we aren't actually informed in how to reach and how to understand patients who have been marginalized. And so when we think about veterans in general, there is a warrior's ethos that asks for self-sufficiency. And that makes it really hard to rely on others. And there's a sense that I'm burdening other people. And so when we consider the cultural lens of the military, we go further into the culture of being Black and brown in this country. And what we often hear from veterans is not unlike what we hear officers say in law enforcement, where there's a different set of experiences when they have a uniform on and off. So what we end with often is a lot of pride in service, but also there's the dealing with inequity when the uniform is off. And so there's this other challenge of then carrying on the weight of service, the cost of service, the invisible wounds that come with service, but also not really being spoken to. And so this fund really allows us to develop a training that will infuse elements of cultural humility for our staff, and not just clinicians, but anyone who can come in contact with veterans, from outreach coordinators to frontline staff members, but also community partners like Harvard Street Neighborhood Health Center. We want to make sure that we're going to communities where there's already been trust established with an agency, and we want to promote then in this curricula of training principles of mutual learning and self-reflection, recognizing that we have power imbalances and implicit biases that can affect how we engage and reach out to those around us who deserve care. So we're hopeful that this is going to start us off on an initiative so that we can be prepared to offer the state-of-the-art care that is within our facilities to Black and brown veterans who often don't know that they can reach out for help, and also perhaps we haven't had the opportunity to actually earn their trust yet.
Yeah, thank you so much, Dr. Chow, and thanks for the amazing work that's done out of Home Base. with a particular focus on our veterans of color. I'm sure we'll have some questions for you later from the audience. I want to now turn to Dr. Mahanya from the Lynn Community Health Center and just to ask Doctor how your Lynn Moving Upstream project works. This is the initiative that you have at the health center, and talk a little bit about how important it is to have staff who represent the communities that you serve.
Yes, thank you, Attorney General Healy. And can you hear me? Just checking.
Absolutely.
Yes, so the Upstream Project, so first we're blessed in the sense that as a health center, we already have a lot of basic infrastructure. And obviously, most of the patients that we serve are brown and black to start with. So the health center, out of our 43,000 patients, about 80% identify themselves as minorities, and about 2/3 prefer their care to be in a language other than English. So a very diverse background. Now, we've had a substance use disorder treatment center for a while. It's well developed. We have about 700 patients in treatment currently, so that makes us one of the larger providers of substance use disorder services. And through the thoughtfulness of my forebears here at the health center, we are also present in 18 of the 23 schools in Lynn. And so we have, by 18, I mean we have 18 behavioral health offices, and then they also all have a psychopharm provided there as well. And one of the things that we had heard of is that there's a program called the ACERT program out of Manchester, New Hampshire, which is focused on identifying children who are exposed to adverse childhood events. You could look that up. It's a formal questionnaire. And it's in the studies in the past have shown that it's predictive. Answering positively to 4 or more of those questions actually is predictive of mental illness, of going to jail, of not graduating, and specifically of developing your own substance use disorder issue later on. And so the Upstream Project is partnering with first responders and the schools. So the first responders, when they get called, if they suspect that there's a potential adverse childhood event happening in the area where they're called, they refer that address to a team that will then do outreach to that family and provide whatever services that family may desire in terms of countering that adverse childhood event. And the idea is that if you can diminish the impact and the length that children are exposed to these events, and you can provide them with support, and you can provide them with more adults that are around them, you can provide their parents with support. The idea is that you're diminishing the impact of these events on the kids to diminish their future likelihood of engaging in behaviors like using like engaging in substance use disorder. And so the part of the grant that we're using is that we are very intentional about hiring a very diverse group of therapists. And what we want to make sure is that we match language and race of our therapists with the population that we serve. We know that that makes a difference. Obviously, we realize that access to any services is the most important part, just have any service. But in addition, if you can do racially and linguistically congruent services with the population that you're serving, we know that the acceptance of those services and of those professionals is much higher. So we will be using the grant to hire more diverse therapists and supporting them in this initiative. We're very excited. I think everybody is always very excited about doing anything around kids. So what's amazing is every single institution that we've approached in Lynn to be part of this Upstream ACE initiative has said yes. And I actually have to point out that the Lynn Police Department actually declined any funds from the grant in order to participate. They say this is something we just want to do it. We don't need any money. So the great thing is that there's this great collaboration And obviously, the Lynn schools were reaching into heavily people of color population. So we're very excited that we'll be able to offer these services. And obviously, we might have to wait until you're running for president, attorney general, before we see the results of it, right? Because we're talking about 10 or 12 years. But we're really hopeful that this will make a huge difference in our community.
Yeah, well, thanks for sharing that. I mean, and I love how you're just as from I guess, a law enforcement perspective, tying the use of that ACER data and getting like real relief kind of, or intercession right there for families on the spot. It's we've seen the problems where there are just lack of connectivity and gaps in the overall systems, right? And that's just such a wonderful approach that you're all that you're taking. And I just I really want to lift up and amplify your commitment to hiring a diverse staff that racially, ethnically matches better with the communities you serve. I certainly know that from our own experience in the office, just how important that has been as we try to get out and talk to people about consumer issues or protecting their rights as workers, or protecting civil rights, you name it. We really, particularly when you come from government, there are some understandably out there that may not necessarily trust government, even like government. And it's been really imperative to connect in that way. So great job there at the health center. So now I want to talk a little bit about homelessness. And we're so lucky to have Dr. Gata here from the Boston Healthcare for the Homeless program, doing outstanding work. And to see if you could talk a little bit more about some of the challenges particular to individuals experiencing housing insecurity, experiencing homelessness they're facing in communities. And, I'm sitting here in Boston, so, I'm not far from, I'm right around the corner from Pine Street, actually. And talk a little bit about what you see and what you experience there.
Thank you so much for the opportunity, Attorney General. And I think sort of in contrast to the work in Lynn that this grant is supporting, we are, I think, kind of necessarily focused pretty downstream, actually, in this epidemic. And so I guess what I would say is that among homeless people in Boston, in our practice, drug overdose deaths is not only a major cause of death among our patients, overdose is responsible for 1 in 4 deaths overall over the last 16 years in our practice. And we've really been diving into the data recently, and we're currently exploring a possibility of a trend that we're seeing in that mortality data that looks like, that appears that overdose deaths are really beginning to level off among our white patients, but that same leveling off appears to not be happening among Black people and Latinx people who we're serving, who are experiencing this intersection of addiction and homelessness, and often cycles of incarceration. So you asked about the challenges. There are many. Maybe I'll just talk about a couple. I think, first of all, at a very basic level, so many of our patients have been affected by the racist war on drugs that has been our predominant policy in how we manage addiction as a society going back so many decades, and has dramatically and probably by design affected people of color more. And as what we now see as a disease, as we sort of shifted our public approach to more of a public health approach, I think that there's some implicit racism even in that shift that we have to recognize. And so I mentioned that first, the racist war on drugs, because so many of our patients are cycling in and out of jail and prison related to their drug use primarily. And so that's, first of all, a big challenge in just providing services and helping people access continuous treatment. Of course, I have to mention too, just the lack of housing. You can imagine how that might affect your ability to be able to accept treatment the way that it's currently designed. So a lot of folks who lack housing right now really fall through so many of the cracks in our treatment system, which is designed really for people who can show up reliably at certain times and be contacted reliably and connect to a broader network of recovery resources. So I guess I would say that there's so many other challenges I can mention, but I think I'll just mention those few right off the bat. And we're really lucky to be supported by this grant. I feel like it's going to help us really mobilize more than we have already to focus in on communities of color in Boston, particularly in Roxbury and Dorchester, for people who live at this intersection of homelessness and opiate use disorder and overdose, very, very high overdose risk. So thank you.
Yeah. No, thank you. And one can only imagine, in this, we're on a WebEx or Zoom right now. I mean, how one is to really access to treatment and care and appointment services when you don't have a computer or Wi-Fi or a stable housing situation. So God bless you guys and all that you're doing out there. All right, well, we'll talk more about that. But I want to bring in from the Gadara Center, Dr. Aviles Hernandez. Thank you so much for joining us this morning. And I guess what I'd like to have you talk a little bit about is your recovery coaching program and why staff with lived experience and multilingual access is so important in your view.
Absolutely, and thank you for having me. Something that we know, but that's become very apparent through this COVID-19 pandemic. It's the fact that our individuals, they need support, and especially those individuals that are struggling with substance use disorders. Something that it's critical. It's the support system that they have in place, and the fact that they can have someone that not only they can relate to, but also can help them navigate the road to recovery. So our intention is, through this grant, it's to be able to create and expand our workforce, specifically recovery coaches. So we're calling this the Recovery Coaching Training to Work program. And the idea behind it is that we, same as many other providers in the state, we've been struggling with recruiting individuals. We certainly have the infrastructure. We've been serving our communities for 44 years. We have many levels of care under our umbrella. We have 5 peer recovery support centers across the state, more than any other agency. But something that we need, it's staff. And something that we've seen through the work that gets done day in and day out is the more that we can support our individuals and our recovery, the better they're going to be at. Better results as far as health and well-being, more stable, and they're able to navigate, again, the road to recovery more successfully. So our idea is to have this program focus on Hampden County, but specifically in the cities of Holyoke and Springfield. And something that we know about that area is over 43% of the population in Springfield is Hispanic. Over 51% in Holyoke is Hispanic. So these are things that we know. We also know that the population that we've been serving through our agency, over 45% of that population that we've been serving, it's non-white. Over 43% of that population, it's Hispanic or Latino. Over 40% of that population, it's bilingual or they speak Spanish. So we know these things, and something that we have always tried to do very successfully, I might add, is have our workforce mirror those of the population that we serve. 50% of our workforce, over 50% of our workforce is Hispanic. Over 18% is Black. Over 6% is multiracial. Over 74% is bilingual or multilingual. So we want to make sure that we also bring that level of expertise, but also that same level of cultural sensitivity, cultural humility, cultural competence to the area of recovery coaching, which has proven to be such a critical piece in supporting our individuals who are struggling, like I said, with substance use disorder. So with this program, our goal is to be able to train individuals with lived experience, more individuals with lived experience, individuals that are currently walking through our doors in our recovery centers or even in our treatment programs, that are very well in their process of recovery, or that may need more support, or that they're looking to have better or more skills, so that they can also have the trainings and the tools and the competencies to help others. This is something that they really like doing. This is something that we've seen day in and day out through our centers. So we want to be able to do more of that. We want to be able to bring these individuals, give them the tools, train them in recovery-oriented systems of care, train them in skills that have to do with cultural considerations, in terms of religion, in terms of language, in terms of ethnicity, in terms of race, gender, and provide them the tools that they need. Because something that we know, and not only do we know because we've seen it, but we also know through the research, is having that level of support through recovery coaching decreases criminal justice involvement, decreases emergency service utilization, decreases relapse rates, decreases rates of rehospitalization, decreases rates of substance use. So if we're able to develop these individuals so that they can not only coach, but mentor, teach, support these individuals in recovery, it's going to be something that is going to be not only beneficial to those we serve, but also to the community overall. So that's the idea, that's the goal. And we certainly appreciate the fact that we have been given this opportunity to be able to do this.
Well, we're really happy to help. And you know, you talk about the dearth. My own layperson's experience is that there's such a dearth of behavioral health providers and recovery services and treatment out there. I mean, as a nation, we just haven't invested in that. The metrics haven't been right. The reimbursement's been lousy, and you know, here we are. And so you mentioned it's even worse in terms of trying to find and recruit people with linguistic, racial, ethnic similarities too. And I think it's a broader discussion about what we need to incent and support in some of our schools too, and training programs and the like. But I spent a lot of time in the Springfield, Holyoke area. I do know of what you speak and how imperative that need is. And I think that model, you know, of having coaches and lived experience, again, you know, from my own lay experience, that seems to be a critical piece too of dealing with issues of particularly addiction. So thank you for being with us this morning.
Thank you.
We're now going to move to Dr. Saya from BMC, Boston Medical Center, to talk a little bit about the barriers, the challenges of working with young mothers and young mothers of color, in particular when it comes to opioid use disorder.
Hi, great. Thank you so much. And thank you, Attorney General Healy, for all of the work that you're doing and then turning this around to help us take wings for all these initiatives. And it's just such a joy to be part of this amazing panel. I want to talk with all of you afterwards. So a little quick piece about Project Respect. Project Respect is a substance use disorder treatment program in pregnancy at Boston Medical Center. Boston Medical Center is a safety net hospital in the city. About 60% of our patients are from the communities of color. Project Respect, however, traditionally, since we've been operating since officially with our name since 2006, has been about 90 and higher % white. And why is that? There's multiple reasons we've been taking a look at, but I think it's this massive intersectionality between the systemic racism of both our medical systems, but also the family court system. When pregnancy becomes sort of the center of these women needing to engage in care, where families of color are overrepresented in the family court systems, are overrepresented in any judicial collision between medicine and law, and our gross mishandling of the crack and cocaine epidemic, specifically for pregnant women, still holds a huge shadow over the trust or lack thereof of communities of color and substance use disorder treatment, specifically in pregnancy. So we have been fortunate enough for several years to have a DPH grant that has partnered our team with an amazing residential treatment program in Mattapan called Entre Familia, which has been doing incredible work for decades, helping Latina and Latinx families heal and thrive with substance use disorder. This grant that your work has allowed us to do is going to help us to create that same partnership that we have with Entre Familia with the Phoenix House, which is also a residential treatment program for pregnant and parenting persons, specifically women of color. So are hoping to use the funding to hire a woman of color peer recovery coach and a administrative or managerial person to create the same sort of intervention program that we have with Entre Familia, where we have teams that go out and do groups at the house for pregnant and parenting women, and have a greater connection with our team at the hospital. And it seems to be so break down so many barriers of mistrust of all the systems. So we're really excited about having this funding and going forward. And Dr. Alves Hernandez, we should probably talk, because hopefully we can have a stream here going forward from your training to our program. That would be wonderful.
No, that's great. That makes me happy too. Anything we can build in terms of connections here between and among folks. But thank you for that profoundly important work that you do day in and day out, Dr. Seha. So now we're going to turn shortly to general questions, but I want to bring on Dr. Abigail Judge from MGH's Bridge Clinic and ask her to speak about her really important work with women of color experiencing opioid use disorder, and in particular, women who have been exploited through commercial sex trafficking. So welcome, Dr. Judge.
Thank you so much. I guess I'll just present a little bit. So we at the Bridge Clinic, these grants are going to help us expand a more specialized team to work with women at the intersection of substance use and commercial sexual exploitation. And women of color are disproportionately vulnerable to this intersection and also the least likely to access treatment. And there's several reasons for that. First, one is that they're more likely to be criminalized, which of course is a form of structural racism, which previous panelists have talked about. And then there are other barriers, one of which is our services we're offering actually attuned to what this population needs and consistent with tenets of cultural humility, starting with what do the individuals what are our services tailored to their lived experience and the importance of that. So there's substantive questions about what treatment should look like. And then secondly, as panelists have already described, women have experiences of racism in healthcare that are decades long, experience of victim blaming, distrust from years of trauma, coupled with provider stigma, not only about addiction, but involvement in the sex trade. And there's really cumulative stigma from both of those things. And so thus this population tends to avoid care actually, except for times of crisis. And so with this support from this grant, we'll be hopefully creating at least 2 specialized referral pathways for women of color to access our low threshold services at the Bridge Clinic. And that's first hiring a woman of color who has lived experience both with substance use disorder recovery as well as who identifies as a survivor of the commercial sex trade, which is a role that has gained more traction, is considered a promising practice more in the juvenile space, but hasn't really been applied to adults, but is likely equally important. And also peer-led services are typically housed in community agencies and NGOs, which are siloed from addiction services. And what we hear from women is that they really desire services all in one place, both peer support, psychological support, and integrated substance use care. And that simply isn't the standard of practice yet. So both hiring this woman who will partner with us, both to serve in that role of recovery coach or survivor mentor, her titles to be determined by her, as well as involved in community outreach with me to develop a streamlined referral pathway, one of which would be from the Suffolk County House of Corrections. So when women are detained and seeking same-day medication for opioid use disorder or whatever their goals happen to be. And then equally important, and what I'm really excited about, this grant will allow us to implement a community engagement plan where throughout the 2-year period of the grant, we'll be meeting with key stakeholders and inviting through an iterative process feedback to, again, answer that first substantive question of, are our services what this population wants first and foremost? Setting aside all the barriers to access that straddle all kinds of marginalized groups, but really substantively, are we offering what women seek? So that's what we'll be up to. And there's so much overlap among all of you, so I can't wait to get together and talk more.
Yeah, that's great. Thank you so much for sharing with us that work. And you know, I look, I don't want to overstate the amount of the grant, but it's a couple things. One, I think it's really cool if you can hire like one person or something. I mean, you have an individual who can come in that can make a meaningful difference in the trajectory of an organization. And two, know that we're going to look to find ways to fund more of this out of our office. I really believe deeply that you know, we need to do what we can to incent investments, and however our office, you know, whether it's settlements with drug companies or others, we want to be there supporting and promoting your work. So just why don't we open it up? I know there are some questions, but you know, before we hit, I should have asked you this at the outset, but I mean, this has been an incredibly challenging year. And just for the benefit of, for me and people on my team, tell us, like, just take a minute, if you would, just each of you, like, what have you seen? What has this meant the last year in terms of your populations? You know, like what's really happening? You know, I can't imagine. There's been some good innovation, right? We know that some things were born of crisis that, you know, have been positive. But give us a scoop on what we, you know, in government need to understand about what's really happening out there in your community. Let's just go around. I'll start with Dr. Chow.
Sure. Thank you, AG Healy. So I think one thing that will probably be echoed by others in this space is that the relaxing of guidelines for telehealth across state lines has been tremendous, because for the patient and for the provider, often there seems like this artificial divide that exists because of state regulations, when really we're talking about the care of somebody who's been isolated. And so for veterans who are so desperately seeking to feel connected and seen, this has played a lot of challenges. And having telehealth has been tremendously helpful. And our hope is that there's continued opportunities to expand our ability to reach than folks across the regions.
I couldn't agree more. And you have my full support for that as a beneficiary myself. But no, that's really, really important. Okay. Dr. Mahanya.
Yeah, It's a good question. I think, we live in a capitalistic society, so obviously, the more money you have, the better you have access to just about anything, right? That's the premise of capitalism. You have better housing, clothes, food. But I think what was really striking during the pandemic is just how naked that is, right? And then that with all the innovation, the more you had in the beginning, the easier it was to adapt, right? So if you had an institution that had a lot of resources, it was so much easier to flip into telehealth or televideo. But also the thing that I found that was very heartening is that there seems to be, at least I would say in Massachusetts, a sort of a consensus that there's a bottom below which people are just uncomfortable. Like we agree that we live in a capitalistic society, but that there should be this bottom that people don't go below, and that people are becoming really uncomfortable with the intersection of poverty and race. And I think it's been very gratifying to see sort of this, people are calling it a reckoning, but it's just sort of this introspection that's happening at institutional and individual level to say, maybe we don't want to live in a society where the discrimination and the inequality is so stark. Maybe we want to do something else. But I think so. I think I've been cautiously optimistic, especially in Massachusetts. When you think of it, really, it's the first time that we've had a pandemic or a societal level event where inequalities and racial inequities were recognized as they were happening, and people are trying to resolve them as they're happening, as opposed to like with Hurricane Katrina, we waited for 2 years and we did the studies and we were like, oh yeah, that really screwed Black people, right? Whereas this time there was this acceptance that, okay, racial inequities is happening and we're going to do something about it as it's happening. So I think that from my perspective, that's been immensely hopeful.
Yeah, and I think I appreciate that, and what's figuring out the how to get there. What to operationalize and what to do to confront this moment. Dr. Gaeta.
So I think when you ask this question about like the impact of the pandemic, I'm going to focus just on people with opiate use disorder who experience homelessness. If you think about everything, all of the messaging, the appropriate messaging about social distancing over the last several months, in our world, that's meant that a lot of the shelters have been appropriately decongested. People have been moved into hotels, gymnasiums, other spaces where they can spread out a bit more. For people who are street homeless and really avoiding even those shelter systems, people have been even more isolated. They've gone even further, sort of deeper into hidden society. And what has that meant for opiate use disorder? In our world, it has meant that people are using alone, which is a very risky practice, more than before. We expect to see an increase in overdose deaths among homeless people in Boston during the pandemic because of more social isolation. I think also it's one of the other obvious things for people who are homeless is that there is nowhere to go to quarantine or isolate for people who are exposed or infected with COVID. So those spaces have had to be created out of thin air. And what I've noticed about that, about testing people, being able to bring them into isolation or quarantine facilities, and now also with the ability to vaccinate people, is just what Dr. Maha and I just explained, that the mistrust has been magnified. It's just so much more obvious of how mistrustful people are of the medical system in the midst of this pandemic. Really hard to convince someone who has no symptoms but is infected why they need to leave this place and be isolated, even more isolated from others. And then finally, I'll just mention that telehealth has been a godsend in so many ways in thinking about addiction treatment. But sadly for us, only about 20% of our patients with opiate use disorder have been able to successfully access us via telehealth. So we've continued to need to have our noses to the grind in terms of outreach and reaching the sheltered population and the people who are a little bit more hidden even than usual. So it's meant a lot of street outreach in an unusual time.
Yeah, sure. Well, thank you for that. Dr. Abeles Hernandez.
I'm pretty much going to echo some of what my colleagues have been saying. If there's something that COVID-19 has done successfully, it's pretty much magnified the disparities, the inequities that our individuals have been facing. So it became, 10 times right there. It's bigger and more visible. Certainly a lot of things. We certainly, like one of my colleagues just said, we certainly appreciate the fact that there's a lot more focus, there's a lot more support, there's a lot more attention being paid to those issues. Like Dr. Kiami said, as they come up, they are being paid attention to, they are trying to be addressed. But then again, we still need to do a lot more of that. There is increased level of access, but like my colleague just mentioned, the individuals that we serve, they're still struggling with accessing care. They're still struggling with accessing services. And when they are able to access services, are those services appropriate? Are those services linguistically appropriate? Are they the services that they need? Are they getting the supports that it's needed? So yes, we are very grateful for the supports that we've received, telehealth being one of the greatest examples. But there's still there still needs to be a lot more effort into just refocusing and providing a lot more supports so that we can create that balance and we can better equip our individuals with the supports that they need, with the skills that they need, with the access that they need. So certainly, I think we're going in the right direction, and I'm grateful for that. But there's still so much more that needs to be done. And I'm grateful for this platform right here, because if anything, it speaks to those efforts and the fact that we are going into that right direction.
Yeah. All right. Well, thank you for that, Dr. Saya, and then Dr. Judge. Just any quick thoughts on differences this year?
Yeah, I would say echo everything that my colleagues here have said about the exacerbation of the disparities. AJ Healy, you had asked, like, what does government need to know? What does kind of legislation need to know? Is reflecting back on this. I would say that in our world of trying to engage pregnant women with substance use disorder to come in for care, specifically those with opiate use disorder, one of the main deterrents and fears of women is that if they begin MOUD, so medication for opiate use disorder, that is going to be part of the mandated reporting of a 51A filing. We are at BMC drafting a much more inclusive document that is a risk assessment rather than a medication flag. And so if we could engage our legislators and all of our collaborators to trust us in saying that we would refer for our risk assessment rather than required reporting because someone is on buprenorphine or because someone is on methadone, would change our practice significantly and try to decrease those barriers of bringing women in that are even more compounded if you're a pregnant woman of color.
Okay, thank you. Thank you for that tip. Great. Dr. Judge.
So I would just add that with our population, women impacted by substance use and commercial sexual exploitation have been at heightened risk for exposure due to chronic homelessness, compromised immune systems, as well as the fact that the commercial sex trade has not slumbered during COVID. That this is, there's no national data available, but I can say anecdotally from clinically and my law enforcement colleagues that there hasn't been a slowing down of the buying and purchasing of sex despite public health guidelines to socially distance. With cheaper hotel rates, there's been a migration indoors, and at the same time, a lack of places of safety and lack of judgment for the population, similar to what Dr. Gaeta said. So I would say that's the less hopeful, persistent dynamic. And then the more hopeful one, I would say through virtual visits, is I've really been humbled by the expanded possibilities is a therapeutic moment, things that I wouldn't have expected that could occur virtually that have been humbling as a therapist. So that's the bad news, good news.
Yeah, well, thanks for both. We should follow up more on the first point you make too. Well, I just want to thank you guys so much for your participation this morning. I want to thank all of the folks who tuned in. And this was a discussion that could have gone on for a long, long time. But, you know, it is just, and I wish we had more time. I really appreciate some of the audience's comments and questions. And, you know, I think that you all should feel good in this time. I mean, we've been through an awful lot as a state, as a country. To me, the one good thing about this is, and it's something that I think Dr. Gita alluded to, I'm not interested, and I think nor would you be interested in going back to the way things were. And I think that through COVID, through the moment of racial reckoning that we're having in this country following George Floyd's murder, you know, there is this opportunity right now to, as things have become dismantled, torn apart, to really build in new and different ways. And I think there is a realization of so much more of the interconnection between health and equity and race, and, you know, it's like it all fits together. You as practitioners know that. You live that every day. Your organizations are about that every day. But I hope that you take heart in this time, that I think a lot more people get it and want to be supportive. I think we're going to look to you all to help us get there, right? And get there in the ways that make sense, and get there faster than we otherwise would have, born in part by this time of crisis, right? And, you know, yes, people recognize now more, and they talk more directly about Black and brown disparities in healthcare, because Black and brown people are dying and getting sick in numbers that are so disproportionate to the population, including here in this state, right? So it's like, you can't turn away from that. You could, but I mean, so it's like, this is the opportunity right now, and building on the amazing work that you all have been doing with respect to substance use disorder, fighting a lot of the stigma in that space. I think we've still got work to do. And I think that, you know, with COVID, some of that has understandably left the front pages, so to speak. But I think this is really important. And I tried to drive that home in our settlement last week with McKinsey and the Purdue, when we sued Purdue and Sacklers, we did investigation and then went after McKinsey, is a way to jumpstart this back on people's, you know, attention and screen. So I want to thank you all as the amazing providers that you are. I want to thank you for the care that you deliver to your communities. And I think you've got to continue to press government and business and all around to hold true to the values that everyone espouses. It was, you know, I didn't see Colin Kaepernick the other night featured in any of Roger Goodell's NFL Black Lives Matter business, which was good to finally see from the NFL. But it's not lost on me that a lot had to happen to get to that point. Now people are at that point. Let's just push forward and make everyone really own this agenda of truly addressing racial disparities and inequities in our society. So my best to all of you. And I hear ambulances in the back. I mean, it's like you guys are right in the, you've got your scrubs on, you're right in the thick of everything. I'm just at home. But thank you for your work, and we'll let you get back to your day and the wonderful ways in which you serve.
Thank you so much.
Thank you so much.
Bye-bye, everybody. Thanks, Emily.